And welcome back to this Dialogue Web Extra. I'm Marcia Franklin, and I'm talking with two administrators of the Department of Health and Welfare. Richard Armstrong is the director of the department, and Leslie Clement is the director of the Medicaid division. And they have graciously said they would stay and answer some of the many phone calls that are still holding on our line. So let's get to that. Let's talk to Holly in Blackfoot. Holly, go ahead, please.
Thanks. I am just wondering what you guys are advising some of the families to do that the in-home care is being cut.
Okay, and are you a provider or are you a client?
Well, I'm actually a provider. I'm an occupational therapist in Blackfoot who are preparing families and work closely with them. My parents are also providers for my brother who does stay in in-home care. And the concern is what happens if they lose their funding. My parents will have to get jobs, and so he might end up in a nursing home.
Okay, I'm going to put you on hold so you can hear the answer. And before that, though, I'd like to roll a piece of tape. We do have some quotes from people who testified at JFAC on this issue, providers who are worried about this same situation.
Any adjustment to the funds or policies in Medicaid that supports my certified family home will result in this family being homeless. I will lose my home.
It is unfathomable that Idaho will essentially lose federal money. We will lose employees with dependents. They will go on unemployment. The dependents will be enrolled in Medicaid. Offices rented will be vacated, and the landlords will be unable to pay their mortgages.
So, to answer this question, and specifically about people like the First Lady who provides in-home services for her children, what are you telling families to expect? Are you preparing them for this? Could they, because they provide DD and PSR services, or no, since those will be cut rather, they might not have those people coming to their home, and then they'd have to stay home and take care of their dependents?
I don't think that's what they're asking. These are certified family home providers, and they're actually individuals that are in a home taking care of either a relative adult or just an adult that needs that care. And I know there's a lot of concern out there right now.
Well, maybe because of the tailored approach, not the blunt approach, but the tailored approach does have some cuts, doesn't it?
No,
so there's no cuts to the actual in-home services.
So, we don't know at the end of this process what services are going to be impacted. But at this time, there's no reductions that are identified for certified family homes. So I know there's a lot of worry out there, a lot of concern, and I think across the state there are a lot of rumors going on and speculation. But I would just say, not for people to panic at this time. Wait until some decisions are made, and once those decisions are made, then we'll communicate.
Okay, Holly, I hope that gave you some comfort. I wanted to ask you, before we take another phone call, how do we compare with other states in this crisis situation, especially our neighboring states?
Well, when we feel real badly, we look at the other states. Washington, Oregon, California, of course, have significantly greater problems. We started reducing our budgets 3 years ago, and we started preparing early. And that, I think, has helped us get to this point as a state in much better shape than many others.
And our eligibility to begin with is tighter, isn't it?
Right, I think that's the other point, is that many other states increase their eligibility, their caseloads, to much higher levels than Idaho. And I know at some point you're going to talk about Arizona, but the caseloads that they're dropping aren't even eligible in Idaho in the first place. So we already ran a very lean, tight eligibility system here, and so we didn't have that extra in the first place.
Right, in Arizona, just referencing the NewsHour is going to be doing a piece on Arizona soon. But because of that, because our eligibility is so tight, there's not any room to go there like the other states have. They can, Arizona or other states that had a broader eligibility can start cutting back on that.
Maybe. Part of our problem was that with the funds that came from the federal government, we were prohibited from reducing eligibility. That's the challenge Arizona is trying to make now, is that with the supposed repeal, or what they hope to be the repeal of the National Health Plan, which carried on that provision of freezing eligibility. So, but it won't help us much because we have very little that we could cut.
And let's talk very briefly before we go back to the phones, this FMAP that changed. Part of the stimulus helped, and we got a higher match rate for a little bit. What, a couple years, a year and a half?
Yeah, it's been about 2 years, and normally the federal government shares in about 70% of the total cost of our program, and during that period of time, they increased that share up to almost 80%.
So now we reach the cliff because in June that extra FMAP, they call it, match rate, is going to start incrementally going down again, but the people on Medicaid in Idaho are not. I mean, it's a pretty stunning figure, 230,000 people, and we're number one in food stamps.
Yes, and it's an early barometer.
Yeah, food stamps being an early barometer. So we're reaching that. Part of our issue, right, is this match rate that's going to go down.
Yeah, because it went from the 80 to the 75, and it'll go back to our original 68%. Probably rise the next quarter slightly.
So should we have not taken it?
Well, I don't think that it would have made any sense not to take it. We were able to do a lot of good for a lot of people in Idaho by having it, not health and welfare. That money allowed the general fund to support all the other state agencies and programs, not us.
Okay, let's hear from Lonnie in Caldwell. Lonnie, go ahead, please.
Good evening. Thank you for taking my call. Wife and I have been certified family home for several years, up towards 30 years. And we've run into several problems. And, you know, you said that the lady said just wait and see what's going to happen. The problem with that, it's a lot easier to do a little preventative maintenance than it is to try to fix a thing after it's broke. And I'm not trying to be a smart aleck here, but they've already cut our agencies right in half.
Can you speak up? Can you speak up just a little bit? They've cut you in half.
Yeah, they've cut the agencies. What we used to receive in the agencies, they cut that right in half. We used to receive $18 a day, and now we receive $9 a day for clients that we have running through an agency. It's mandatory that we have an agency, otherwise we can't function. And so when the agency goes out of business, what's the provider's going to do? The certified family home going to do? Now, I'd like to leave one thing else with you. Like I say, I'm not trying to be a smart aleck, but I would be willing to pay half the bill if the legislature and all the people up there running the legislature would be willing to pay half of it for me. Cut. You take a cut, and I'll take a cut. Okay?
Okay, I'm going to put you on hold, Lonnie, and let's try and get an answer to your question.
Thank you.
This is circling back around to the family, the in-home providers still being worried about cuts, and you heard what he said. What do you have a thought on that?
Well, we don't have a plan, so I appreciate what he's saying. Is it would be nice to have some lead time and preparation time, and that's the really challenging thing when you're facing a budget shortfall as immediate as July 1. So we hope that we'll have some decisions soon, and as soon as we find that out, then we can start responding and preparing for the next fiscal year. I don't know specifically what agency rate reduction he's talking about, but
that's pretty stunning from cut in half like that to $9 a day.
I don't know what that is.
Okay.
And just to elaborate on Leslie's point is the decision will be made by the legislature. We've put forward a matrix of options where and how much those options are worth. We don't know what the combination's going to be, and it won't be our decision, by the way. We will certainly administer that decision, but it really is in the legislature's hands to help craft what that mix is going to be.
Well, Lonnie, I'm sorry we can't give you a more permanent answer on that question, but thank you for calling.
Thank you for trying. I appreciate it.
Let's talk to another person from up north. Dory in Sandpoint? Dory?
Yes. Just a quick question. The fairly new implemented AMR transportation service seems like an unnecessary middleman. How much would the state save by just cutting that out?
Okay, thank you. I'll put you on hold to listen for the answer.
Well, the AMR, it's a selective contract. It's called a transportation brokerage. And that contract was just implemented in November. And it was implemented to save the state money. And that was about $500,000 that it is
Why?
expected
How is
to
it
save.
saving money?
Because it's a single entity that handles statewide all the transportation scheduling, so that instead of individuals passing each other in trips on the road, it's all coordinated.
To their DD centers and things like that?
Well,
Or to
to
their doctor's
also- to
appointments? Or
the
I
whole
see.
array of services. And so, you know, early implementation, there were definitely some problems, and but we think that it's going to be a more efficient system after it's been settled for a while, and it does intend to save the state money.
Thank you so much for your call, Dory, on that issue. And you know, people are very concerned about another contract that was let, which was with Molina, which is the provider of payments to these people, the agencies and the in-home providers. They didn't get paid for many months. There were lots of computer problems. Where does that stand right now with Molina?
Well, we meet every Wednesday with the senior leadership of Molina, and we've laid out a strategy which is working. We've vastly improved the overall performance. We're getting about 82% of the weekly claims are processing through, you know, without any difficulty. So we're feeling that it's getting its legs. However, like any huge system conversion, it takes some time to work through all the bugs.
Has Molina been paid?
We have not paid them, you know, since June.
And will they be penalized for the issues?
That will be a legal process, as the contract outlines, to determine what the damages are and then what those damages are worth.
You know, people look at situations like Molina or the lady calling in about transportation and these contracts, and they say, here's all this money going out, and yet you're talking about cuts. You know, why are you paying an agency that, or a company that apparently hasn't been working correctly, at least until recently, while we're looking at the cuts? Do you feel that changing the contract to Molina was needed to save money in the end?
No, the Molina contract is the heart of the Medicaid system. So every state Medicaid system relies on what's called a Medicaid Management Information System to pay all its claims. And the federal government requires that system to be recontracted, you know, every so often. So you don't just pick a system and stay with it for life. And that's not in the best interest of the state anyhow, because you have
So you had to change.
We had to change. It had nothing to do with budget reductions.
Okay. Let's take a call from Beverly in Boise. Beverly, go ahead, please.
With all due respect, the Molina system is not working, and we haven't got paid for 2 weeks except for half of what we're owed. That wasn't my question. You just happened to talk about it. My concern and my question is, there's so much talk about the lack of money and not being able to raise tax and all that, but we're talking about people's lives who may not live if they don't have some of these supports. And I just wonder why everyone's so opposed to raising some taxes or whatever to actually keep these services going. It's not just to prevent homeless, it's to save lives.
Let's put you on hold and get an answer. Now, I know neither of you can address specifically your opinions on taxes. That's a function of the legislative process. But if a cigarette tax were to pass, which is being proposed, it sounds like that could help you significantly. They say $51 million or something like that, some of it into cessation programs, but others just into to the general health and welfare. So I'm kind of dodging around here, but is that something that you're not opposed to, or can you take a stand on that?
we've heard the same reports of, and we heard all the testimony last Friday about getting the cigarette tax or tobacco tax raised. Clearly, if that is done and a portion of it is dedicated to Medicaid, then that will dramatically change the scope of the cuts that will need to be made. And clearly, from the caller's perspective, it would greatly relieve that negative impact on people of Idaho.
Do you think it's an appropriate tax since it has to do with medical care in the end, you know, people smoking or?
Well, it's hard to say. A year ago there was some interest in raising the beer and wine tax to pay for substance treatment because there was a feeling of cause and effect. We're pretty agnostic about the source of the funds.
Yeah.
If we are allowed to make a significant change in what we have to reduce, and then we'll be pleased with that.
I think we want people to have healthy habits, and we want people to stop smoking, and we want them to eat well, and because we do end up paying for chronic disease, we end up paying for those high-cost medical services. So,
speaking of eating well, I did want to clarify something with you. We had an email come in about food stamps. And this person standing in line, looking at what people buy with food stamps and the health of these people, and that they're allowed to buy all these sugary things, and that if you were able to just cut back on what these people are allowed to purchase or streamline the food stamp program, you could save money and give it towards Medicaid. It's not that easy, is it? The food stamp program and Medicaid don't. There's not a nexus.
No, there is not. Food stamps is a federally driven program. The state of Idaho does the administration, but all of the dollars that pay for the food, which is about $300 million a year now in Idaho, comes 100% from the federal government. They control what we can allow on the debit card. It frustrates me that they can buy sugared sodas and other non-nutritious food, and we have requested in the past for some flexibility in being able to make changes to the roster of items. So far they've said, no, that's not in our control, that's in the federal control, and we hope that someday there will be a change of attitude.
I was remiss in not asking you in the main program something about one of the things that's in your blunt approach, so to speak, of your potential cuts, and that is copays. We do have 2 emails about this. Why are Medicaid participants not required to pay copays? It would seem that most of the working poor or disabled participants could at least afford a $2 copay. If they can't come up with $2, maybe the service is not really medically necessary. And another similar email, the majority of us either have a copay or deductible. Why not a $2 copay?
well, copays are on the table. And we would be looking at something in the neighborhood of $2 to $3. Medicaid has a lot of protections, though. There are a lot of people on the Medicaid program that are exempt from copays, and they're exempt because they're in special classes. So, for example, all kids under 18 that are Medicaid eligible can't have a copay applied. Well, look at Idaho's Medicaid program. Most of it is children. So most of the individuals on Idaho's program wouldn't be allowed to be assessed a copay.
And let's take a look at that blunt approach graphic again if we can. As I recall, it does not raise that much money, $4.3 million from copays. Is that in part because you estimate people just can't come up with the money, there's no way of policing it? Or I know you have I know you have concerns too about people just not using this service because $2 to them is quite expensive.
Well, the way that we will administer copays is we will reduce the payment to the provider, and the provider will be responsible for collecting the copay. Now, we're not naive. We know that the provider will, in many cases, not be able to collect it, and they're just taking a reduction in pay. Copays in the private sector are used to reduce utilization. In some cases, especially with those that have mental illness, a reduction of utilization may very well be a dangerous thing because they may then not take their medication. They may not do something that would keep them safe in their own home. So there's balances here. Now, we will go to we are proposing copays, and that is one way to try to solve this budget problem. But it's not being done without a very realistic view of what will happen.
An interesting email here. Do you think providing participants with an explanation of benefits would be a good way to detect provider billing issues? I called Molina about EOBs, is what they're called, for my daughter who's on the Katie Beckett program, and I was told that giving me that would be the same as my employer giving out my paycheck stub. She feels that this would be a way that participants could help assist you in preventing fraud and billing issues if she could see the statement for her daughter.
Well, I'll follow up on that, because that's not an accurate or appropriate response. I think that historically, even under our old system before Molina came on board, individuals on Medicaid didn't get explanation of benefits, and primarily because most of them had no cost-sharing responsibility, and there was some concern that it would be confusing and it wouldn't be helpful. But we've heard from a lot of people they'd like that information, and especially families like that, we've specifically asked that they do get that information.
Because they're profoundly disabled, it's very high cost probably. That's some of the services that are
and it's an ability for the families to review the charges and make sure that those services were actually received by their children. So we absolutely support that.
Give you that information. And let's take a call again from up north. Nice to hear from you, Deborah in Rathdrum. Deborah, go ahead, please.
Yes, we've been hearing horror stories about what cuts are going to be made to certified family homes. Could you tell us what is on the table right now for the certified family homes?
Okay, and perhaps you weren't listening before. We did have a question about that, but we'll reiterate it because it is so important to people. Cuts to certified family homes, people who take care of individuals in their own home, mostly a lot of times their own relatives.
So we've heard a lot of these rumors for some time, and at this time, there's no proposed cuts to certified family homes, neither in their rate nor in the service.
Okay. Hopefully that gives you some comfort. As we wrap up, I wanted to ask you a couple more questions. You have employees of your own that are leaving, and I think in a rather poignant part of your testimony to JFAC, both of you discussed this. You've had some very valuable employees leave, as a matter of fact, and you talked about this being one of your greatest fears and worries and keeps you up. They're leaving because of stress in some instances, caseloads and stress and
so we've had our workforce reduction like the private sector has, and so but the workload keeps on increasing. So you saw the caseload, so we have more individuals to serve with about 12% less staff to respond to.
Let's put that graphic up again about the growth in Medicaid. This is very interesting.
So it's harder. I mean, the nurse reviewers out throughout the state, going out into individuals' homes, assessing them for eligibility for waiver services.
Give us an example of like a typical, like a drop in staff that's worrisome to you.
A lot of our turnarounds in authorization for services, our pharmacists, returning calls used to do it same day, and now it could take 2 days or 3 days just because we don't have enough staff resources.
We compete in the healthcare market, and the healthcare market really didn't slow down during this recession. And so our skilled players certainly are going to look for job opportunities when it's been, be 3 years and there's no increases in wages, and the stress level and the work level continues to climb. So it's just a reality in which we have to operate.
Why do you want your job?
I wonder sometimes.
You came from the private sector, 36 years in private healthcare.
Yes,
and you've been doing this for 4 years, and this is a sometimes thankless job.
Sometimes it is. However, it gives me a great sense of pride to see what we've been able to accomplish, the improvement in productivity, the fact that we've been able to deal with these 10 and 12% cuts in staff and still deliver high quality service. That's only because of the excellent group of employees that we have and their commitment to service. And it's an honor to be a leader of that organization.
Mm-hmm. And Leslie, as we wrap up, what's next? The legislature has to make these decisions. Mm-hmm. Even after the legislature makes the decisions about which way would they want to go, either the blunt approach, the tailored approach, or some hybrid of cuts, it still has to go before the federal government, does it not?
Yes, it does. So what I would expect is that there'll be policy drafted through state law that would identify what kind of cuts would be made. That has to be all voted on, approved at the state level. After the legislature adjourns, then our agency has to start putting together the amendments to those, what we call the state plan. And that state plan is our contract with the federal government that says, here are all the benefits, and we have to start saying, we want to remove this. And they have questions often about that.
So it could be a process that goes well into
Months.
2011, and you might have to ask for, or the services may continue, in fact, until the federal government approves or doesn't approve what you've asked for.
Sometimes it sort of depends on what it is.
Sometimes you can get a temporary
Right.
waiver. Well, thank you both for staying and answering these additional phone calls and emails. You've been listening to a Dialogue Web Extra on the subject of Medicaid cuts. We've been talking to Director Richard Armstrong of the Department of Health and Welfare and Leslie Clement, the Director of the Medicaid Division. I'm Marcia Franklin. Thanks for tuning in.